A very good evening and warm welcome to whoever are attending this webinar. So since we are in the month of mental health awareness, and that's a very important topic because since we being diabetologists, physicians have been treating with diabetes for so long, and diabetes itself is a chronic disorder. Along with diabetes, complication like micro and macrovascular complication, depression has been often neglected. And the reason might be like we are too busy clinicians, or there might be some, patient just consider this is a very natural process, or anything everybody has to go with that. But no, because it plays a significant role in management of diabetes. So mental health is very important and a pillar kind of just management of diabetes. So here, Empower, in association with TIA, comes up with a session based on mental health and how to come up to the patients once they are diagnosed with diabetes. So Empower is a platform with all the physicians, diabetes advocates, nutritionists, dietitians under one umbrella who has a passion to treat type 1. So today our moderator, I feel so privileged to invite Dr. Indra Shees. He is diabetologist from Lucknow, and the speciality about him is very spontaneous with his shairis. So anytime he can come up with his shairis. So I'm very glad to hear one from his mouth. So I hand over to Dr. Indra Shees to take it forward. Thank you so much for patient hearing.
Thank you so much, Manisha ma'am, for your kind introduction and for your kindness and kind introduction. And now proceeding towards our session, I would like to invite Dr. Mayura Chaudhary Kale ma'am. She is consultant diabetologist and physician at Dr. Kale's Diabetes and Psychiatry Clinic, Chhatrapati Shambhaji Nagar, Aurangabad. She is visiting diabetologist Disha Neuropsychiatry Hospital, Dr. Radio Maternity Hospital, Ishwar Hospital and Research Center, Sanjeevani Children's Hospital. She has awards and recognitions to her credit. D Next Generation Award for Diabetes Care, Hello Diabetes Academia, Nagpur, and Special Recognition Award for Paper Presentation at CDI International Diabetes Summit, Pune, and part of contributor to various publications, clinical trials, conferences, presentation, and educational activities. Now I would like to, ma'am, just and also Dr. Kashyap Modi. He is also our second speaker for this session. He is founder and consultant diabetologist and physician at Trident Hospital, Gandhinagar, consultant diabetologist at Diacare, Diabetes Hormone Clinic. He is MD Medicine, Fellowship in Diabetes, PGCDM, CCGDM, and fellowships in 2D echocardiography. This is all he has in his credit. And now I would like Dr. Mayura Kale ma'am to take forward for this session.
Yes. Thank you so much, Dr. Indrajit, for this kind introduction. Thank you, Dr. Manisha Gupta, for this invitation. And thank you, Dr. Educator Riddhi Modi, for all the fine coordination. And obviously, thank you, Team USV, for the technical support. So when I got to converse with Dr. Manisha regarding this session, I was like, what I should speak about in type 1 diabetes, since it is a very difficult and much discussed topic. I think quite a lot details are always discussed. So I realized that I deal with a lot of patients when as soon as they are diagnosed with type 1 diabetes, still in ICU. And my job is usually to educate as well as convert them from IV insulin to the subcutaneous insulin. So this is for the first time in their lives, these children are facing insulin and all the obviously the diagnosis of diabetes related anxieties, and also this is a very difficult phase, I feel, for them as well as the parents. And it is associated with a lot of psychological trauma, you can say complications later on little bit, depending upon how the parents take it forward, the child takes it forward. So I thought I'll speak a little bit about this and share my experience about this. I hope my slides are clear.
Yeah, visible, ma'am, visible.
So breaking the news to the child and to the parents and managing the denial at the time of diagnosis in type 1 diabetes. So whenever there is diagnosis of type 1 diabetes, as I said previously, it's a completely life-changing and emotionally overwhelming diagnosis. There is denial, anger, guilt, depression, lot of mixed reactions. And the first conversation of the diagnosis, which we do with the parents, with the patient, completely sets the tone for the lifelong diabetes self-management in that particular child. So it is our responsibility, the team's responsibility to do it very sensibly and very responsibly. This is very important, I feel. So we'll discuss the psychological stages after the diagnosis. What are the denial patterns and how, I mean, how to recognize them, how to deliver a structured communication technique when breaking the news, and how, what are the supportive strategies for acceptance and coping. So I would be discussing mainly from the diagnosis to the first 1 month, you can say, because the management later on may be a little different, but the first month, first few days and first few weeks are very important in this aspect. So this is a case of a 10-year-old child who was previously healthy. He's a grade 4 student and he doesn't have any significant past medical history. A short bout of fever around 1 week, since 1 week. And he presented in diabetic ketoacidosis, diagnosed to have type 1 diabetes. He was given IV insulin, IV fluids, complete IV ICU care, and now he is hemodynamically stable and is accepting some feeds now. Now it is the time to switch to diet gradually and switch to subcutaneous insulin as per his oral intake. So what happened? His father came to me and he told me, no, 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 he cannot have diabetes. Nobody in our family is having diabetes. You know what happened? He had a lot of stress of the exams. He ate a lot of sweets, cakes and all. And that is why he must be having raised sugars and it will go off. You know, doctor, you agree with me, na? So this is a kind of denial. Obviously, you all will be able to tell that. What are the common phrases? Not my child. My child cannot develop diabetes. He was not. He never had any diabetes. We don't have any diabetes over. And I feel the test might be a little bit wrong. It is a little bit showing a little bit higher, but it will go down after his stress period goes down. And it's temporary. You agree with me, na, doctor? Because it's temporary. Now, after this is over, he will be off insulin. He will not require any treatment. Maybe he'll get just control with the diet and all. These are the very common phrases indicating denial. So we have to listen to them properly and understand what kind of denial is this. So what is understanding denial? What is denial? Denial is, it's a refusal to accept or believe the diagnosis in spite of the reality that it is true. It is a kind of psychological defense against the overwhelming fear which that person, the parent or the child is facing at that time. Because you know it's very, very difficult to accept that within suddenly in few hours for them, in few days, that the life is going to change forever. This is a psychological defense, but to tell you, it's a kind of normal thing we should treat as. Even if this happens to any of us, we will also be in the same phase for at least some time. Even if we are doctors, we our relatives are doctors, everyone around know, we know everything, but still we may also go through this phase for maybe a short period. And they are common lay people. They are bound to have that reaction for a longer time. So when dealing with such parents or child, we have to be really empathetic and we cannot be really very in hush hush. We should be little quiet, listen to them, and then just we should not react immediately to this. So, what are the forms of denial? So, it can be outright refusal to believe the diagnosis. Maybe my child doesn't have diabetes. So this has happened occasionally in the ICU. That when we told, when the patient was out of that critical care ICU, and we were planning to shift the patient, to the child, to subcutaneous insulin, they literally said, no, 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 we will take it to some other doctor, and we don't believe your diagnosis. And they took, hopefully good must have happened with the child, but this can happen because it depends, many a time it depends on the relatives and the parents, uh, you can say, understanding level. Sometimes very low understanding, it is difficult and it might happen. We should take at most care, but there might be chances of this happening. So outright refusal to believe the diagnosis, downplaying its seriousness. So as I said previously, so father or mother will say that, or parent, the relatives around will say, it is going to have, don't worry, that it will, now he's requiring insulin, after some days he'll be controlled on diet. So it's like downplaying its seriousness. Avoiding necessary management tasks like blood glucose monitoring or insulin injection. This may not be seen immediately in when the patient is admitted, but sometimes if the patient comes after 1 week or 10 days, that time the parent will tell, no, 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 the afternoon dose of bolus is not being taken because he's busy in the school, and we don't want to give insulin in the school. It's difficult to give insulin. There will be multiple reasons they will give us, but they will avoid necessary management. Why does it occur? As I said, it is normal to us as well as to them. But why does it occur? First is, there is trauma of sudden ICU admission. You will understand this very well, because when whoever is seeing ICU patient, there is always trauma to the patient, the relatives. That sudden trauma is there. There is a shock of lifelong insulin dependency. There is a fear of complications, monitoring all the time. This is a very natural thing at that moment. And there are misconceptions about diabetes reversibility. They feel that it is just for short duration and it will go off, as I said. So all these things, this will lead to the denial. The emotional journey of the patient. The child may be withdrawn or rebellion. I see very commonly, so kind of Arav, that Arav, what happened to Arav when I went to next day? He didn't speak much to me because it was like he was like kind of withdrawn. Though he understood, he didn't understand few things, he understood few things, but still it was a kind of a shock for that little child, and he didn't speak much to me. Mother felt that he had fever 1 week ago. I should have shown him to the doctor earlier, and this wouldn't have probably happened. So was it my fault? These different kind of emotions will come to the mother, to the parents. So they will display guilt. This kind of emotional journey will be there. So what happens in typical cases? I said there is shock, there is denial, followed by anger. So many a times that anger may not be directed towards us, but that may be directed towards the staff. That anger may be directed towards by mother to father, father to mother, something like that. This is very common. Also, you must have observed that the relatives many a times talk very rudely to the staff. They may not talk to doctors, but certainly to staff they may do so. So this is a kind of anger. They are venting out their emotions of anger onto them. They are not really bad people, I would say. It's that the reaction of that moment, and we have to understand, and maybe little patiently we have to speak. Later on, that there will be a stage of bargaining. That means that they will say again, as I said, can we take little less frequent insulin, so twice daily only instead of 4 times daily? Can we stop? Can we monitor less frequently, maybe once in a week or once in a month? Is that fine? And later on, gradually, maybe within a week or 10 days, there might be some kind of acceptance. The acceptance part takes a lot of time in many patients. I had a lady who is a very good mother of a type 1 child, but that after 2 years, she took almost 6 months to accept it and to normalize. Whenever she would come to my cabin, she would cry. She would cry, why this is happening to my child? That was the kind of longest period I have seen. But most of the parents take around 2 to 3 months to accept and get stabilized. So this this period of 1 to 3 months is very crucial, I feel. And we should be very, as I said, patient, listen to them, listen to their problems. Dr. Manisha just now mentioned that we don't have much of time. In that case, we can ask our nutritionist, our diabetes educators, our other team to take care of them, and maybe they can give us feedback regarding what is the problem. Sometimes patients, the child and the parents don't talk to us directly, but we can take feedback from them, and then we can take appropriate steps accordingly. Parents go through the grief of loss of that they call healthy child. As I said, there is anxiety about future complications, safety, and certainly we have to, for at least some duration, we have to validate these emotions as normal and manageable. We should not really scold them for repeatedly behaving in the same way or repeatedly showing the same emotions. Maybe, as I said, it takes some time for the parents and the child to normalize. And it is for us, it is very important that we validate these emotions as normal for some duration and manageable. So, breaking the news, the communication framework, we call it as spikes communication. It's a short form, that is setting. So, choose a quiet, private, unrushed environment. Sometimes it is not possible, but what I do when I go to the ICU, there is a small chamber in the ICU, beside ICU. So, I call the parents, the relatives, and then I tell most of the times, because in that hush hush of ICU, it is very difficult to speak very, you can say, properly to them. You can ask what the family already knows, that is perception. So if they are having kind of right perception, we may step to the next, we may go to the next step. We may just improve few things. If there is a lot of problem with the perception understanding, then maybe we'll have to give more time to that family. Ask them, I mean, we have to ask them whether I can share all these things. Not exactly ask in our settings, because probably this is more for the Western people, but in our setting, we'll have to tell them detailed information depending upon the understanding, the educational background of that patient. We should obviously deliver give knowledge, deliver the diagnosis in clear, simple, factual terms. But as I said, we should be soft. We should not be rude. That is very important. And as I said previously, again, we have to acknowledge that feelings of fear, anger, disbelief, and we have to end with hope and clear action steps what we are planning. Truly speaking, when we break the news, we cannot really end up here with the conversation. This never happens. I take typically 2 to 3 days in inpatient setting. First day, I discuss few things. I tell them the diagnosis, what is the future things, what are the options available. Maybe I give a small task, but second day I tell them about the more of other complications, what are the precautions to be taken. Third day, I ask them, I revise with them many a times. So what do you remember of this? And I ask, what over last 48 hours, what do you feel? What are the challenges you feel you are going to face when you will go home? All these things, maybe SMBG, these things we discuss. But it takes maybe more than a week of breaking the news. Actually, breaking the news, it's not just telling the diagnosis of type 1, but educating the family is also important. So what are the words that will help, and what are the words those will hurt? So helpful are the one we'll work together to help your child to live a full life. This is very important from our point of view, that we give confidence to the parents, that the child also, that he or she can do whatever she wants to do in their life. So we have to avoid that you don't have any option, this is going to be lifelong. Kind of rude conversation is not really advised. And empathetic framing emphasizes on the capability, what the child can do in the future, and not the limitation. This is very, very important. Whenever there is transition from ICU to home life, we have to gradually shift the focus from stabilization, hemodynamic stabilization, orals and all, to to the empowerment. And obviously, most of the diabetes educators, they provide structured education sessions about insulin technique, SMBG, hypoglycemia management. We can obviously provide them written and digital educational resources for reinforcement, so that whenever they are at home or whenever we are not around in the hospital, they can read and learn, because empowering them is very, very important, because that is the way they will have confidence in themselves and they will go ahead in their lives. We have to facilitate the acceptance. So encourage small and achievable self-care goals. What I do in the hospital, as I said, first day I tell them add healthy diet, and I give only few options of healthy diet, and I ask them whether you could add this in on the second day. Second day I tell them to learn how to take insulin injection. Third day I tell them how to see the blood glucose level, and probably on discharge we tell them how to manage the dosages, how to see prevent hypoglycemia or check for hypoglycemia, manage hypoglycemia. This is very important. But certainly these this is not sufficient. We have to reinforce, especially the managing blood glucose level, when to increase the blood insulin dose, when to reduce the insulin dose, how to use basal insulin, when to use basal insulin, when to use bolus insulin. This is very, very important. That takes some time, obviously, at least some few months, couple of months, and I feel that's a very dynamic process. It keeps on changing, and that we have to keep on doing. But certainly at initial stages, we have to tell them, and we have to teach stress reduction techniques. Frankly speaking, this is again little difficult to do in our setups, I feel. But we can tell them how to do deep breathing, especially parents who are suffering from anxiety, depression. These things may help them. And we have to always reinforce normalcy in every visit, not even during the diagnosis or around that time, all the time, because we should not let them forget that it's normal. Maybe in people who are managing it well, you may not reinforce it, but otherwise, whenever you find one or two points while speaking that they are feeling limited in their life, we should always reinforce that. Early identification of distress is very important, and it prevents burnout and disengagement from the insulin therapy. We can offer short-term professional psychological counseling, especially after discharge. We can watch for anxiety and depression. But there is one study, a systematic review, which is done, and it has shown that 50 to 70% of the parents, they suffer from anxiety or depression. 50 to 70%. This is officially documented figures, but I feel at the time of diagnosis and post diagnosis, post discharge for at least 1 to 2 months, 100% parents are anxious. Maybe there may not be depression, but some or the other, uh, to some or the other extent, they are certainly anxious, and they are anxious till that child takes over his or her own diabetes management, insulin injections, monitoring. Then only they are, I can say, they are little normalized, and it takes many a times, as I said, 6 months to 1 year at least. Relational family therapy, it is very important. Maybe those who have done a landmark forum kind of curriculum, they understand. So whatever this through interpersonal and systematic metrics of family relationship, type 1 diagnosis may be there, but previous to that, there may be certain issues in the family, unhealed wounds. There might be some you can say conflicts, maybe small conflicts, but they might be there. So ideally, we should we should solve all these conflicts. So maybe a father may not speak much about diabetes, though he's worried, he's caring, but he may not speak out much. So we will have to tell a father that you speak little bit more to your child, express your warmth, express your feelings. That is very important for the child. And sometimes, as always said, the mothers are very nagging, and you may have to tell that mother that maybe how to stop, or sometimes she has to maybe take a back seat and act. So this is kind of, you can say, relational family therapy. There might be some conflicts between the parents, and that should not come into the management of diabetes of that child. These are very important. Maybe the, you can say, grandfather, grandmother, these are also, the extended family is also very important, especially in Indian setup, because we know they make a lot of difference in our life. So relational family therapy is one important thing I said. Maybe not at the time of diagnosis, but post discharge 1 or 2 months, it will make a lot of difference. And in India, as I said, we have to tackle the stigma, because it is considered to to have diabetes is considered as stigma, to take injections. There may be a marriage prospectus, there is fear, there are myths about insulin, about side effects. So we have to speak in a language that will blend science and compassion. Only compassion, that is only being very sympathetic, is not useful at all, because being showing sympathy means that child will feel that, oh, I'm so poor, I'm having a lot of problems. That should not be the approach. We have to empower that child, and we have to obviously speak with compassion, and obviously science, because we have to make that child empowered, confident about management of his or her diabetes. If he or she is confident, she will certainly do very well in his or her life. And we have to integrate family elders in the education sessions as whenever possible. Support group, peer models, they are also important. There are communities, the type 1 community, the Blue Circle Foundation, Empower Diabetes, which Dr. Manisha is involved, Riddhi is involved. There are a lot of other channels which I recommend. I think Mehak is also doing very good. So I tell the children with type 1 diabetes to follow them on the Instagram, or you can see the YouTube videos, because whenever they see someone like them, they are obviously empowered. They are very the kind of which depression or anxiety which it goes off. And again, as I said previously, there are a few studies where the parents feel that group therapy was much more effective than the individual counseling, and that is why parents they opt for group therapies, and that support groups everywhere, and that gives very good results in them. So I have a girl of type 1 diabetes, so she likes to make reels, dance. So I tell her, you make reels, certainly you make reels, because her mother was really worried she will be dancing, there will be some problem. I said, no, not at all. She can make as many as reels she wants. In fact, I would encourage you to make reels which are educational, especially for people like children like her who are have dealing with type 1 diabetes. And I think she's making reels now. So my key takeaways are: denial is a natural, but it needs guided transition, especially from us doctors. First is very important, followed by the diabetes educators and nutritionists. Compassionate and consistent support is very important. It prevents the disengagement from the therapy as well as the lifestyle modifications. Early family centered counseling is crucial for long term adherence, and breaking the news with empathy is therapeutic. It's not just informational. So thank you very much for patiently listening, and thank you, Dr. Manisha, Riddhi, Dr. Indrashish, Dr. Modi, and USV Tech team. At the end, I would like to say families don't need insulin prescriptions. They need hope, skills, and a team walking with them. Thank you again. Thank you very much.
Thank you so much, ma'am, for your excellent deliberation regarding this very important topic as of type 1 diabetes. And if there are any questions, we can take up after some time, after the second session of Dr. Kashyap Modi. Yes, ma'am. Okay. So now I would like to proceed for the next session. And Dr. Kashyap Modi, the stage is all yours. You can present your slides. Thank you.
Thank you so much, Dr. Indrasis, for your kind introduction. And I would like to thank Riddhi, Indrasis, and Dr. Manish and entire T1D team for giving me the stage. it is very difficult for me to share the slide after Dr. Mayura ma'am presentation, but I would try to justify my slide.
Sure.
Just a second. Okay. Uh, so my name is Dr. Kashyap Modi, and the today's topic is breaking the news, managing the dynamic of diagnosis. And my motto is to this presentation is delivering a type 1 diagnosis with care and confidence. So we all know that the receiving the news of type 1 diagnosis is life-changing moment for both patient and family. They experience emotional shock, fear, and uncertainty. So the manner by which we, with how much clarity, empathy, and hope we can deliver the news, it fundamentally shapes the long-term acceptance and the treatment areas and quality of life of patient. So in this, our words and approach is the critical moments matter deeply for the patient and the family. So why our uh, approaches matter. So our approaches matter for treatment acceptance and medication adherence, for emotional well-being and mental health outcomes, and to develop trust in healthcare teams and medical system. Long-term disease management success is also based on our first approach. There is critical connection between our approach and the treatment. If our communication is poor, then the poor communication lead to denial, which may result in delayed insulin initiation and potentially life-threatening complications. So for that, we have to understand the emotional landscape of patient. There are several emotional landscapes, like Dr. Mayura said, there are certain stage of grief. So we understood in which stage our patient come to us. If patient in anger, then we can't consult patient with same way that the patient is in shock form. राइट हम सबको एक तरह से ट्रीट नहीं कर सकते एंगर वाले पेशेंट को भी कान से कि यू हैव टू एक्सेप्ट योर डायबिटीज टाइप 1 you have to take lifelong insulin so we have to understand in which stage of denial is patient and treat according to that so we are trying to understand what is denial. So basically denial is a psychological defense mechanism. Denial is actually made up for us. It is not a bad thing. So the denial serves as a psychological defense mechanism that protects our emotional overload. Is particular common in any chronic lifelong condition like type 1 or any other grief. Any person who receive a bad news go through the denial. While usually it is temporary, denial can significantly delay proper disease management and insulin therapy. So we have to understand what is denial and what are the stages. So based on the Elizabeth Kubler-Ross, there is a 5 stage of denial called DABDA. It is also called as the grief stages of grief. So first is denial. In this patient is initially disbelief for resistance. Like patient said, no, it is not possible. I have type 1 diabetes. The second stage is anger or frustration. Like this, why me? मुझे ही क्यों हुआ ऐसा दूसरे किसी को क्यों नहीं हुआ then the stage is come called bargaining in this the patient seeking for alternatives like I can manage diabetes by exercising. They go for alternative medicine like Ayurveda, homeopathy. Uh, Yes, and then the next step is from depression. In this stage, the patient feel depressive. Why this चीज happen to me? अब मेरा क्या होगा? अब मेरी पूरी लाइफ में मैं कुछ कर पाऊंगा या नहीं कर पाऊंगा? Similar ways, family के मेरे बच्चे के साथ क्या हुआ? If my child is uh, able to live his normal life or is able to his job or her job, right? And the final stage comes acceptance, and then they are moving forward. The denial for phase is often long in type 1 diabetes families, and sometimes it's uh, like lasting weeks or months. Like ma'am say, her one patient is taking 2 years for accept that. This is very long period. So the how we recognize the denial in clinical practice. So there are some tips by that we can know that our patient is in denial phase. Like he or she miss appointment, treatment non-adherence, stopping insulin by herself or not taking correction dose or proper insulin. Doctor hoping he go for one doctor to another doctor to please stop my insulin by anyhow, and that minimizing result, they are deliberately so low blood sugar, or say my sugar are all good without checking it, and avoidance behavior, refusing to discuss on diabetes or changing topic. If you ask about her diabetes, or he got anger and suddenly he changed the topic, or just stand up and move away from your side, or don't want to talk about this. So these are the core principle of breaking the news. First, prepare. So before the breaking the news, review all the reports thoroughly and ensure a private, comfortable environment free from interruption. Just prepare by yourself and then assess. Understand the patient family's current knowledge of and level and prescription about diabetes. So just prepare a silent room and understand about your patient and your patient family knowledge about that, and then deliver a clear jargon-free language paired with genuine compensation and unhurried presence. Just tell them in layman language or directly that you have a diabetes with some empathy, and you don't require to hurry. Just yeah, I want to see another patient. Give him or her proper time to discuss about her disease. Response: acknowledge emotional authentically, allowing space for tears, anger, silence are needed. So just see their response. If they are crying, they are anger, just go with them and allowing a proper time to them, and then plan for the discuss next immediate step gradually. Avoid the overwhelming the family with too much at once. uh, we should just plan a small step, like after 2 day follow-up, 3 day follow-up. We don't require to tell on the first day you need lifelong this, you have to take about the diabetic nephropathy, diabetic retinopathy. We just slowly educate about the diabetes, and then prepare about them to managing the diabetes and managing complication as well. Obviously, the MEM speak about the spike communication framework. Is a very good framework. It is contained as per setting, create a privacy and comfortable space. P for perception. You have to understand what they are know about disease and what you have to put up after knowing their understand about the disease. Uh, Invitation. You have to invite them to um, uh, so you have to invite them to share your knowledge and ask what you don't want to, what would you like to know from me, or what you would like to share right me. Then the knowledge, emotion, response to feeling with empathy. I can see it. This is overwhelming, and the strategy. Outline concert next step, ensuring they don't leave alone. So these are the some words that help, and then hurt. I understand this feeling overwhelming right now. We walk through this together step by step. You feeling are completely valid. So you have to talk very empathetically with your patient, not just हट के you have to accept, तुम्हें टाइप 1 डायबिटीज है, तुम्हें एक्सेप्ट करना ही है, तुम्हें लाइफ टाइम इंसुलिन लेना ही है, वरना तुम्हारा बच्चा ये हो जाएगा वो हो जाएगा. इनिशियली यू हैव टू टेक विद एम्पैथिकली कि यह सबके साथ होता है, तो आप अकेले ऐसे नहीं हैं, बहुत सारे ऐसे पेशेंट हैं कि पेशेंट इन ग्रीफ स्टेज, लाइक बार्गेनिंग स्टेज, देन यू हैव टू, कोई दिक्कत नहीं, बहुत सारे ऐसे बच्चे हैं जिसको डायबिटीज है, अब ऐसे ऐसे करके आपको कॉप अप कर सकते हैं. सो यू हैव टू अंडरस्टैंड द फेज इन वेज फेज ऑफ पेशेंट इज दाबड़ा, like deep denial, anger, and try to move forward this stage, and finally lead to them with acceptance with your clinical knowledge and expertise. Tell them about the insulin treatment, reassure important history. So educate them about what is insulin. Before 1920, if there is no influence, the family and doctors both are helpless. There was no cure and no hope. And tell them after 1921, Benting and Best discovered insulin, and the insulin is a boon to a mankind. Is turnovers to non-manageable disease to manageable. This ensures about the insulin today. Insulin is a natural hormone, not a punishment or failure. आपको समझाना है कि इंसुलिन आपके शरीर में बन नहीं रहा है, तो सो यू हैव टू टेक इंसुलिन. वो कोई पनिशमेंट नहीं है, जो आपकी बॉडी नहीं बना पा रही हो हम बाहर से दे रहे हैं. अगर आप उसे लेते हो तो पूरी जिंदगी आप आराम से जी सकते हो, like that. And you can also give an example by nearby your child or any peer communication. The one is the famous example I mention is this is the Leonardo Thompson. He is the first person who got insulin. You can see in the first photo how much malnourished he was when he diagnosed with diabetes. After receiving treatment, these both are his photo. How gentleman he's look now. So by educating them, you can कन्विंस अबाउट देम इंश्योरेंस कि आपको कोई डरने की जरूरत नहीं है, इंश्योरेंस कोई ऐसे कोई बुरी चीज़ नहीं है, आपको लेना है. आपको उसके आसपास का आपके पास जो टाइप 1 के पेशेंट है उनका कांटेक्ट करवाना है, फिर कम्युनिकेशन करना है. स्मॉल स्मॉल उनकी विक्ट्री होती है, उनको चीयर अप करना है. यस, आज आपका शुगर कंट्रोल आया, बहुत बढ़िया बात है. अगर आपने टाइम CGM लगाया और टाइम इंडेक्स बहुत अच्छा आता है, तो भी आप उनको चीयर अप कर सकते हो, उसके फोटोज शेयर कर सकते हो. सो बाय दैट दे वर मोटिवेट. So this is the strategical moving forward together. Denial is reversible when met with consistent empathy, education, and support. Involve the whole family. So you have to involve the whole family. So celebrate small wins, like I mentioned ago. Connect with peers, like introduce organs like tie up power, empower type 1D, real world inspiration and community, and use motivational interviewing. Just interview with frequently them and motivate them. Uh, the healthcare teams play a vital role. In healthcare team, we require doctor, obviously diabetes educator, mental health provider, and peer support. I personally felt that if the one of them is type 1 diabetic patient, like doctor, diabetes educator, or peer supporter, then patient is very much emotionally connected with them, and patient is rapidly accept his disease and go forward for go further for treatment. So I would end my presentation with this quote: "We can't change the diagnosis, but we can change how it receives. Information overload fails sometimes, but compensate guidance succeed." Thank you. Over to you, Interview.
Thank you, Dr. Kashyap Modi, for your nice deliberation. And really, you explained each and every point of your presentation in a very precise and also in a very elaborative manner, touching your personal experience also. So,
Thank
thank you
you.
once again. Now, I am sure that our participants must be having the questions with them to ask both the speakers. So, Dr. Mayura, ma'am. Uh, Welcome, ma'am.
Yeah, I'm here. Yeah.
Our participants must be having questions with them.
Yes, we
So
can take them.
we can take the questions. In the meantime, if the questions are just coming to roll the ball in, I think I should ask the question first to to both the speakers. Ma'am, uh, as you both the speakers have already explained each and every part regarding type 1 diabetes management and what are the issues we tend to have in our personal experience in our day-to-day clinical practice. So, but still, I just ask a simple question that if a girl child comes to the comes our clinic or our hospital and she is diagnosed with type 1 diabetes, the scenario comes that कि मेरी बेटी को ये बीमारी हो गई, अब तो इसकी जिंदगी खराब हो गई एंड अब शादी तो हो ही नहीं सकती, इससे शादी कौन करेगा? So that is the main trauma the patients face or thinks, and the girl also is in a fixed situation. Ke, now my life is finished. So what should be the step? But I know the steps are already been described. But the initial management and what type of steps should be required to treat that patient in that process?
First of all, as I said, I would listen to them completely, because if we listen to them, then only they feel that we are really interested or we are really treating kind of thing. Then I have few type 1 ladies now who are having children and who have managed their type 1 diabetes very well. Their children are almost now 10, 15 years old, and they are doing very good. They are pursuing their profession, they are pursuing their hobbies. So I give the examples, because when we talk to people with type 1 diabetes, it is always the peer which makes a lot of difference rather than we
Yes.
directly. This is my common observation. I mean, this is everybody's observation. So I tell them, I give them examples, and then they are a little bit convinced. And it is like I show tell them the scientific findings also, what is happening, what are the new insulins coming in, and how they are making a lot of difference in pregnancy as compared to the previous pregnancies. The complications rate are have really gone down. We have Rutul joined, I think. So Rutul has done a lot of work with a long
Yeah.
acting this glargine in type 1 diabetes. So I tell them that my friend has really worked very well in this, and he has got very good results. So we have just what we have to do is we have to keep the HbA1c as normal as possible, avoiding the fear, like avoiding hypoglycemia as much possible. And the baby she is going to be a very perfect normal lady with all the development of secondary sexual characters as well as everything. And obviously fertility will also be very good. She will deliver a very good, very
And
you can
if
say
the sugar
healthy
is
child.
controlled, then the no hormonal issues will also be there.
Will
No
be
hormonal
there,
issues.
yes. So and since we have a lot of good options for insulin delivery, we
The
have long
management, yeah.
acting insulins, and whenever possible, those who can afford, they are having they can use the pumps also. With pumps also, my
Insulin
friends in
pumps, yeah.
Mumbai, they are using pumps, so they are getting very good results over there. So there are a lot of options, and obviously, as you mentioned, during the pregnancy, if the blood glucose is normal, the baby is going to be perfectly healthy. That
Yeah,
is very important. Maybe
absolutely, absolutely.
pre-conceptual counseling will have to do little more frequent monitoring, more frequent visits that will have to take care. But certainly she can deliver. So we have so much of data with us. We have people leading by example with us. So obviously, most of the
And I think, ma'am,
parents,
day-to-day counseling is very much required. Day-to-day
yes,
counseling and advocacy counseling to patient as well as their parents.
parents
Both
is very
should
important.
motivation कि नो नो सब
Yes.
कुछ ठीक है, ऐसा कोई दिक्कत नहीं है, सब ठीक हो जाएगा, अच्छा है, ओके,
हाँ,
कोई बात नहीं,
ये
हुआ है, आगे होता जाएगा, ठीक हो जाएगा. तो द
सही कहा.
मोटिवेशन, रेगुलर मोटिवेशन इज रिक्वायर्ड, आई गेस.
It's very
तो मैं
important.
योर
Backed by the
कमेंट्स.
scientific data.
या, ओके, थैंक यू. योर कमेंट्स, डॉक्टर मोदी.
आई थिंक मुझे लगता है कि अगर ये जो आपका क्वेश्चन है उसमें पीयर कम्युनिकेशन का ज़्यादा रोल रहता है. कि अगर आप टाइप 1 वाली बच्ची को उसके फादर को सेम डिसीज वाले बच्चे फादर से मिलाओ, उसको बोलो
हम्म.
देखो ये भी नॉर्मल लाइफ जी रहे हैं, आप उनसे
हम्म.
कम्युनिकेट करो, क्लोजली मॉनिटर करो, क्लोजली फॉलो अप लो, तो उसमें एक्सेप्टेंस जल्दी आएगा. क्योंकि कई बार ऐसा होता है कि वो लोग अकेले पड़ जाते हैं, वो लोग अपने
हाँ
4-5 लोगों में ही घूमते रहते हैं कि बस मेरी मर्जी का
ऑब्वियसली,
सब है।
बिल्कुल
तो अगर
बिल्कुल।
वो खुल के सबके सामने आएंगे तो
एंड दे
उसको
थिंक एज अ इट इज एज अ कर्स फॉर देम कि भाई मेरे ही घर में ऐसा हुआ।
यस, तो
सो
वो बहुत सहम जाते हैं वो लोग। अगर आप फैमिली को देखो सहम ही होती है, सिर्फ 4 लोगों के बीच में होते हैं, किसी को और पता ना चले, कहीं बाहर नहीं जाके
या
अच्छी
करेक्ट
इंसुलिन कहाँ लगी। तो
करेक्ट
इफ
करेक्ट
we connect with them other people, then
या
they are openly and they are, the real development start after that.
वेरी वेरी करेक्ट वेरी करेक्ट। So I would like the participants, if they have any questions, they can ask. Our speakers are on board. Any questions from the participants?
No, sir, as of now, we
Yeah.
have not received them.
Okay. Okay. So shall we wrap up the session now?
Yes, sir, sure. No problem.
Okay. Okay. So thank you, ma'am, and thank you, Dr. Modi, for your excellent deliberations. So today we had the privilege of hearing from exceptional speakers who shed their light on the crucial aspects of type 1 diabetes management. Your both of the expertise and passion are truly inspiring. So we are not only educated, we are really very much convinced to how to treat our type 1 diabetes patients in our day-to-day clinical practice. So thanks for education and giving knowledge and sharing our personal experience with us. This would really be very helpful for us in our upcoming future. Thank you, Dr. Mayura Kale ma'am and Dr. Kashyap Modi, for your precious time and nice deliberations. Thank you once again, ma'am. Thank you once
Thank you,
again.
Dr. Indrashish. Thank you, Dr. Modi. Thank you,
Thank
Rutul,
you,
and
Dr.
thank you, Tech
Anderson.
Team. Bye.
Thank you, Dr. Mayura. Thank
Thank
you,
you.
Dr.
Thank you.
Rutul sir.
Thank you, ma'am.
Thank you.